So chapter 24, part 2, we're going to continue with the trauma overview. And now that we have reviewed motorcycle crashes, we are going to look at falls. Keep in mind that falls are a significant risk. And when we have that fall, we are looking at our greatest potential and our greatest threat coming from the internal injuries. Obviously, the greater the height of the fall, the greater the injury potential. And those patients who fall from greater than 20 feet, that's considered significant. And you've got to remember that that's 20 feet from the height. So they may be standing on a 15-foot ladder, but if they are 6 foot tall, then technically you are looking at 21 feet that the head fell from. Patients who fall and land on their feet may actually see less internal injuries. So if you're a cat, you have better luck. And it's because of the fact that the fall and the energy from the fall is actually absorbed in their ankles and their lower extremities. Now that of course means that you are seeing a higher potential for significant damage from the feet to the hips, but that's easier to recover from than significant damage to abdominal injuries. Some of the things that you need to take into account when you have a fall is the height of the fall. So like I said, the greater the height, the more potential for injury. The type of the surface that was struck. And let's be real, from a great enough fall, it really doesn't matter what you land on, it's still going to hurt. And then the part of the body that hits the ground first. So, does the head hit first, or does the arm hit first? All of these are issues that will be a concern when you're trying to assess what has happened. We need to consider next, outside of blunt trauma, penetrating trauma. So penetrating trauma is the second leading cause of trauma death after blunt trauma. And penetrating trauma means any injury that causes a break in the skin and damage to the areas beneath that. So impaled objects, gunshot, knife, that type of stuff. And it may be accidental or it may be intentional, so we have to consider that as well. When you have a low energy penetration, these are normally just stab wounds, impalements, when kids are running with a pencil or scissors, those types of things. Knives can be low energy, but if they are moved around, if the blade is serrated and not straight, you see a greater chance of more significant internal injury. When you're considering projectiles such as bullets, you need to remember that just because the entry wound and the exit wound are kind of in the same place, it's in the shoulder and in the front and in the shoulder and the back, doesn't necessarily mean that that is the straight path. A bullet can enter the body, or a projectile can enter the body and actually follow the curve of the bone. Or it can cause significant damage based on the path that it takes. And then if it fragments after it hits something, or if it stops, if it's a bigger bullet, or if it's a shotgun, those factors are all going to impact the internal damage that occurs as well. Cavitation is the result of the rapid changes in tissue and fluid pressure. So as that projectile moves through the body, you will see cavitation occurring. And this then can result to injuries to internal organs that maybe weren't even in the path of the projectile. So again, just because you know what the projectile is doesn't necessarily mean you can guarantee what the internal injuries are. Penetrating trauma is going to have a relationship between the distance and severity of the injury, and that's going to be based on the type of weapon. Areas damaged by projectiles is going to be bigger than the diameter of the projectile. So just because the bullet is small doesn't mean that the damage is minimal. And the energy that the projectile has, as we said, has to be transformed. And so that is going to be transferred into the body, causing tissue and organ damage. Table 24-1 provides you kind of the mechanism of injury and signs and symptoms and what you should be suspicious for various different types of traumatic injury. And we will talk about each of these in different chapters throughout the rest of the book. Blast injuries is an issue that we don't see a lot of, but it can happen. We need to consider the types of things that may cause a blast injury. And since I'm recording this on April 15th, one of the most recent blasts that happened was the Boston Marathon bombing, and the injuries that occurred from that were significant. But most of the time we consider blast injuries coming out of military conflict. So blast injuries have 4 levels of injury that will occur. The center there is the primary blast. So this is going to be the initial blast wave, and those who are closest to the blast are going to be impacted by it. Secondary blast injuries are due to missiles that occur as a result of the initial explosion. So it's why we see terrorists putting projectiles into the bombs, tacks, BBs, anything, screws, nuts, bolts that can be flown and flung from the center of the primary blast. Then you've got the tertiary blast injuries. Tertiary blast injuries occur when there's an impact with another object. So because of the initial pressure wave, I am flung against a wall, and injuries that result from that are considered tertiary. And then quaternary blast injuries. Those are kind of those miscellaneous injuries that occur as a result of the explosion. And so that might be burns or crush injuries because of debris that falls on top, or toxic explosions, any issues that we had. You've got, and look, this is the slide going over it, of course. So primary blast injuries being damage to the body by the pressure wave, secondary being struck by flying debris, tertiary being a victim that is hurled, and you may not strike anything except for the ground. But if you leave your feet from the force of the blast and get injured as a result, that's a tertiary injury. And then the quaternary, which are those extra injuries that occur as a result, whether it is the inhalation injury, the burns, the crush injuries, those types of things. And you're not necessarily going to be calling it into the hospital saying, be advised, I have tertiary injuries. But what you are going to do is you're going to need to keep in mind that most of your patients are going to have a significant different levels of injuries. Organs that are hollow, that contain air, are more susceptible to injury from pressure change. So the ear, the lungs, anything in the gastrointestinal tract, and the ear being the most sensitive. It's why when somebody is suffering from a blast injury, if they talk about having been around a blast, you end up with hearing issues, at least the ringing in the ear initially. Pulmonary injuries are a huge concern. Damage to the lungs as a result of the pressure wave, as well as anything inhaled. You need to be cautious with these patients because they're going to have change in behavior, change in their neurological status and their hypoxia. Their oxygen levels are going to change, all significant issues as a result of the blast injury. Thankfully, solid organs are fairly protected from that pressure blast, but they are going to get their damage from the secondary missiles or the tertiary injuries. Um, you know, you've got neurologic basically it's a full body issue. And then as we saw after Boston, one of the big issues was traumatic amputation. The way that they had designed that bomb was to hit the lower extremities of anybody who was close. And as a result, we see a significant number of victims who came away from that having lost one or both of their lower extremities. Multi-systems trauma refers to a patient who has multiple body systems injured as the result of a trauma. So head and spine trauma, chest and abdomen, extremity damage and abdomen, fractured legs and spine injury. If it involves more than one body system, you have a patient who has multi-system trauma. And this is going to be a high priority patient. Any patient who has multi-system trauma is high priority. So when you are treating your trauma patient, nothing really changes in terms of your main priority, because just like medical, your main priority is your safety. You can't help your patient if you get injured. And your secondary priority is your crew, because they can't help you help the patient if they get injured. And then you worry about the patient. And you also, at this point, then need to determine whether you need additional equipment or additional assistance and evaluate the mechanism of injury. That mechanism of injury may be obvious based on the dispatch information. Just like your medical assessment, once you've done that, you need to identify and manage your life threats. Do you see anything immediately that tells you if you don't treat it, your patient will die? And normally that's going to be significant bleeds or obvious respiratory issues. Once we've done that, once we determine that they don't need, or they do or don't need C-spine immobilization, then we're going to move on to our ABCs. We're going to check our airway, our breathing, and our circulation. We're going to treat any major threats that happen there at your primary assessment, and we're going to choose to transport, whether it's a high priority or low priority. We need to remember that on-scene time should be less than 10 minutes, and that we need to get them to the definitive care within an hour. So our secondary assessment and our sample should be in the back of the ambulance. Physical examination. The traumatic and trauma patient assessment is going to be much more hands-on than our medical assessment is. If you remember, we talk about multiple head-to-toe assessments. So we are doing the rapid assessment with the bleed check, and then we're going to come back down and do a head-to-toe assessment for any deformities or traumatic injuries that we need to treat. If it's not a significant mechanism of injury, so it's more of a low priority, my patient is complaining of, just knee pain or ankle pain, then I'm going to do a focused physical exam, and I'm going to assess just the area of complaint. We need to consider all of the issues that will arise based on the injuries in the body area. Knowing that if we have a head injury, then we are looking at a significant likelihood of bleeding on the brain, impact to the neurological status of our patient, impact to the general function of the brain itself. So is the brainstem potentially impacted by this? And then we also need to consider that even if they have a head injury, they may not initially show signs and symptoms. Injuries to the neck and throat are going to be concerning because this is where you're going to immediately have airway problems if that happens. You've got to look for swelling that could prevent flow of oxygen or blood to the brain. Looking for tracheal deviation, so If you were to feel down your throat right now, you would feel that the trachea is in the center of the neck. But if there is a lung issue, then there will be shift in the trachea to either one side or the other. All of these are going to be things that you're going to find when feeling the neck. Any penetrating injury could potentially cause an air embolism, which is obviously very deadly. Any crush injury could not only impact the trachea, but it could also impact the cervical spine in the back of the neck. So while you do want to put your hands on and assess, you also want to be cautious in case there is damage that you don't make it worse. Injuries to the chest bring about concerns about the lungs and the heart. These organs provide oxygen, they move the blood, are very important in the ability for us to live. So an injury there is very life-threatening. Broken ribs might damage the lungs. Traumatic injury to the chest could bruise the heart, impacting its ability to circulate blood. And then, of course, the potential for large vessels that may be torn. If it's a penetrating chest injury, then you've got the potential for bleeding or air. Any type of open chest wound can result in shock, and if untreated, then death. The abdomen contains many vital organs as well, so any damage to solid organs increases the risk of bleeding. Any damage to the hollow organs increases the risk of spilling toxic fluids into the abdominal cavity, such as stomach acid or bile. Any of the large vessels that are flowing through the abdomen could be damaged, causing internal bleeding that could be deadly. We need to understand that while we don't want to stay on scene too long, we also have to be able to appropriately assess our patient to ensure that we provide the life-saving treatments that may be necessary. Critically injured patients need to be on scene less than 10 minutes, but you won't know they're critically injured without an appropriate assessment. And you have to make sure that you are packaging your patient for transport appropriately as well. Choosing the right type of transportation method plays a role. If your patient is easily accessible and can be loaded quickly, then you want to transport them via ground. If the patient has an extended extrication time, it takes some time to get them out or get access to them, you might want to consider a helicopter because of the need to get them to the hospital as quickly as possible. Additionally, a facility or a transport through a helicopter actually provides access to critical care nurses and paramedics that might be able to provide additional assistance. We can also know that there are organizations out there that are providing guidance and guidelines for those patients who are best transported by ground and those patients who are best transported by air. So you want to keep that in mind and be familiar with those criteria. That's not saying that you can only transport certain patients. I think when in doubt, you definitely want to make sure that you reach out to medical control or even to the EMS supervisor on shift to assist in making certain decisions. Once you know how you're transporting them, you want to make sure you transport them to the right place. So there are different levels of trauma centers that exist, and each of them provides a certain level of care. Level 1 trauma centers being the top level of trauma center designation. These are usually the university-based hospitals that have access to 24/7, not just on call, but on campus medical staff. They serve large cities and populated areas. A level 2 center provides initial definitive care. They may have specialists on call, but not necessarily in the facility, accessible to treat your patient. A level 3 facility can normally provide assessment, resuscitation, initial emergency care, enough to stabilize. But if this is truly a significant trauma, they're then going to transfer those patients to a higher level facility for assistance. And then level 4, those are really in the remote outlying areas. They provide kind of advanced trauma life support, but they're definitely more for the stabilization before moving them to another facility. We are lucky to have MCV close, and that is a level 1 trauma center. We even have UVA, which is a helicopter ride away. And then there's level 1 down Norfolk General Hospital down in Hampton Roads, and then Inova Hospital up in Northern Virginia. And then the rest are kind of level 2, level 3, Chippenham and Johns Chippenham, they're level 2. And those designations require that they show and demonstrate that they have the capabilities to provide the appropriate level. We do have, MCV is also a pediatric trauma center, as well as an adult trauma center. And you definitely want to make sure that your receiving facility can take care of the patient. So as you learn what they're capable of, you may want to call beforehand before making that decision to say, yeah, this is where I'm going. And it may be that you need to go to a lower level to stabilize the patient so that they can then transport the patient. But if you show up with a multi-system trauma to a level 3 and they're not aware that you are coming, it's probably not going to be received well. So communication with the receiving facility is definitely important. And then you've got the trauma triage plan. So the trauma triage plan that's shown on the screen actually provides a way to assess your patient, kind of follow this flow chart to determine whether or not, at what level trauma center that they need to go to. So that exists. It's not necessarily something that most people follow step by step, but it is something that everybody is familiar with. Some of the special considerations when dealing with traumatic injury: first, stay calm. It can be a crazy scene, especially when you're looking at a significant multi-system trauma or a multi-patient traumatic call. So just stay calm, stick to the basics. Remember your ABCs. There's a reason I'm reminding y'all to always look and follow and remember the process. Because if you stick to the process, then it will kind of flow without having to immediately consider it. If it becomes second nature to stick with the process, to follow step by step, versus going, step A, step D, step C. Oh God, did I do step D? What about step B? I didn't do it. Focus on our life threats. Remember to do no harm. And never hesitate to call for assistance. The earlier you recognize the need for assistance, the better off you will be.